Morning, everyone, and I welcome you all to this live webinar with a very esteemed surgeon and a legendary teacher. Words will fall short if I try to describe him, and he's no other than Professor Chintamani. So, welcome to you and good morning. So, we received lots of positive feedback and many requests to have more of these webinars. And we are immensely thankful to you, sir, for sparing your time again to share your knowledge and wisdom with all of us. We are all excited to hear from you again, sir. And we hope that you all are able to listen to us.
Good afternoon, everybody. And a lot of you had actually asked for the discussion on unexpected encounters. But first of all, let me welcome you once again to webinar series, and hopefully you will find it useful, like you mentioned last time. And we are going to start with a very, very important topic, that is unexpected encounters during laparotomy for acute abdomen. Well, the message that you got indicated that it's for acute abdomen, but generally I'll cover up for unexpected encounters because a lot of you asked. Now, during the presentation, if there is any query or question, please post it in the chat box. We'll notice. And I'll request you all to switch off your webcams for the time being, and also you're muted, so that we can then later on have a discussion where you can all interact with me. So without much ado now, you can now see the screen. I think you can. So if you can, please say yes. What are the expected encounters in laparotomy? Well, every laparotomy, according to me, is waiting for something unexpected to be revealing itself. So take it as encounters that you would almost always have, because every laparotomy is a challenge. When I talk about unexpected, it is mostly in situations which are unusual, or when we think it's not working for you, that you made a working diagnosis and the diagnosis doesn't work out, then those are the encounters we refer to. And it refers to emergency laparotomy. I'll try and change the color of the unexpected encounters and emergency laparotomy. These are the catchwords today. So we will make it a point that we'll cover up most of the unexpected encounters. Now, whenever you're doing an emergency laparotomy, it is either being done for the intestinal obstruction, perforations, trauma, or any inflammatory condition or any infective disorder in the abdomen. So we open up for something that we have made a diagnosis of. But many a times it will be without a diagnosis, and you should be, in that case, prepared for it. Now, a question that you would all be asking, are they truly unexpected? But remember, operation is a silent confession to the surgeon's inadequacy. It's a old statement by John Hunter. And in the backyard, you can see his picture. In the back side, you can see the backdrop. That's a Hunter picture. Anyway, so now he was of the opinion that if you're surprised, it's mostly because you didn't think well enough. So most of them should not be unexpected, and we should be looking at them with suspicion from the very beginning. So I'm just trying to move these slides. That's where I'm concentrating for the time being. So what are we looking at? Unexpected. And I'm using the word encounters because I'll take it as a challenge, and I'm taking, obviously, surgeon as a soldier, and that too an infantry soldier. For all those who have served who would know about it, infantry is called the queen of the battle, and the the surgeon is there for the king, and he should learn to handle these emergencies. In well, so I am comparing an emergency surgeon to an infantry soldier to start with. Therefore, what I would teach you and share with you is essentially the cardinal rules of emergency abdominal surgery. If you can't hear us, please let me know because the net connection is not that great, and we have to struggle to let you know that it is clear. Now, in terms of what to expect and what not to, operative surprises are naturally subjective. You're more surprised if you're not prepared and if you do not know the plan B. So if there is no plan B, it is expected that you would be surprised more often. Taking care of the enemy within, very, very important. And I've used the word performance status of the patient as well as that of the surgeon. Enemy within, which means the performance status of the surgeon, becomes quite important. And saving your own men, that is reducing morbidity. It's entirely the approach to war by a surgeon. So you should reduce your mortality. So that is what your aim is. Destroying the enemy before it destroys you, that is saving lives. Very, very important. And it's so apparent in today's scenario of corona infection that when you're confronted with an unseen or invisible enemy, don't make your the strongest part visible. And knowing your enemy, if you do not know your enemy, you're bound to fail, which I would refer as scoring the disease. Very important. So to run through it again, I would compare an emergency surgeon to an infantry soldier. You must follow the cardinal rules of the war in emergency surgery in terms of what to expect, what not to, and in terms of the surprises being subjective and the job being totally dependent on how much you actually know about the plan B, as I mentioned, taking care of your enemy within. I think this is something which is important. I just dwelt into it to make it a point that you need to fix yourself first. Performance status of not only the patient but of the surgeon is also important. If the surgeon is not ready for it, he's bound to fail. And then, as they say, take no casualty, take no prisoners. Destroy your enemy before it destroys you, and save your men. That is minimum mortality and morbidity. How would you do this all? By scoring your patient, by knowing your enemy. If I have to talk about what do you do for a patient with perforation peritonitis, a lot of you have been asking questions. What do I do in a gastric perforation? What do I do in a particular situation? The answer is simple. It depends on the score of the patient. If the patient score is good, you can do many good things. Simpler procedures. The score is bad. Patient is not really uh, uh, fit for a very definitive surgery, a very, very definitive intervention. Now, the cardinal rules continue, and you must pay attention to it. Knowing your men. If you don't have a strong army, if your men are not brave, and if your your army is not, the slide may move a little sluggishly because of the internet connection. Knowing your men, which means the risk-benefit ratio of therapy, having the plan of support from air, which is important. Keeping the battle from front line and not rear, important. Taking advice from the journals, which means what? Your senior resident can give you an advice, your junior resident can give you an advice, but the decision is yours. Don't try to think I called up and I'm done because that's the end of it. No, you should learn to take an advice in the right spirit. Then, importantly, I think this is what makes a surgeon living and dying by these decisions. So, you must take these decisions and you should learn to live with them. To revisit all these cardinal rules, know your men, which means risk benefit ratio therapy. If you find that the treatment is going to be worse than the disease, patient doesn't need to be interfered with. Air support, usually you need air support when you're losing the battle on the ground and you're having a hand-to-hand battle. I'll just give an example of infantry. It works out the best here. You need an air support. The air support uh, in the form of airports, as you know, in the wartime, can really be handy to save our men from dying. And then you keep fighting from the front line. Don't go behind asking somebody else to take those decisions. Classically, a consultant asking a registrar to carry on and then disowning what the registrar did, and the registrar asking the PG to do it and putting the blame on the PG. That's like fighting from rear, something that should never be done. Importantly, the advice. It's very common for people to give you advice after it has been done. Everybody has a great hindsight. In surgery, it doesn't really help because we have it, M&M meetings, which is mortality and morbidity meeting. But these are only to do an audit. An audit doesn't help you in making a decision. When you're taking an advice, take it in the right spirit, but at the same time, make it a point that you don't live by that advice. You have inputs and then you act. Then you should be able to say that promptly, strongly, and confidently. I did it, and I'm capable of taking a decision. So, right or wrong, a decision not taken is a wrong decision, and the decision not taken on time is a wrong decision. Now, so we have so far seen the cardinal rules, which are about the decisions being emergency decisions being subjective. So it'll depend, and you'll have to be tailored to the patient, to the situation, and to the surgeon. Enemy within, that is the poor performance status of the surgeon and patient both should reflect. If you don't know something, don't do it. You have to learn it. Take advice from the journals, that is from seniors and also from the juniors, but the decision would be yours. Now, if you don't know that the decision can be made by anybody, then if you take another person's opinion and you make your own decision at the end of it, mind you, it becomes your decision. And you should be able to live and die with that decision. That's precisely what I was trying to say. A good surgeon lives by his decisions or her decisions. That's the important take home. I'm giving you some cardinal rules, and you will find that they're very handy for you in life. Avoiding friendly fire. Do you know what it is? In a in the in the in the front line, some of your army could have crossed over, and you still continue to fire. You're likely to cause them damage. So that's iatrogenesis. Don't cause damage. Above all, do no harm. Primum non nocere. Sparing your own men, reduce morbidity. Don't kill your own people. So don't cause any morbidity by your intervention and save your ammunition. I can quote an example in Vietnam War, the classical way a guerrilla warfare would succeed, or also in Sri Lankan War, that they would just fire once. It's a guerrilla group, and the organized army keeps firing till the last shot is fired. And when they're without any ammunition, they are surrounded. So do not waste your resources. Use them right. Dangerous and commonly observed, and especially in settings where there's no antibiotic protocol. Attacking at soft points. tailor your management to disease and patient. That's reinforced because it is important that we are able to take a call on what we need to do. Repeating what I've said, I'm repeating everything that I'm saying, and basically, it is to let you know what I'm trying to draw an analogy from. Minimal or no morbidity, primum non nocere, which means above all, no harm. If you cannot think about a better alternative, go for the plain and simple treatment, or keep it simple and stupid, as I say, or keep it simple and safe. And at the end of it, you will have to reduce morbidity somehow and conserve your resources. So I'm actually giving you some cardinal points when it comes to taking care of your resources, the management, etc. Now, there are many ways to skin a cat, like there are 100 ways to Rome, as long as you reach there and you reach alive. There is nothing new in the story. This is a beautiful Winston Churchill quote. Want of foresight, if you lose, that is. It's a classical example when you start blaming, it went wrong, patient was not too fit, I was given the wrong kind of an advice, this was not available, that was not available, etc., etc. But please summarize all those untoward accidents that happened during the emergency surgery where you had a not a good outcome. You'd find this was necessarily, it was mostly on account of want of foresight and want of foresight, then unwillingness to act when action would be simple and effective, lack of clear thinking, confusion of the counsel until the emergency comes, and essentially what it means is when you could have done a simpler job earlier, you end up doing a major job later, which is going to be worse, which is due to lack of clear thinking, confusion of the counsel until the emergency comes, until self-preservation strikes its jarring gong. This is a Churchill quote. So plan it early. That would be simpler, less morbid, and it will be possible to do and get away with less. That's the aim of what the last slide was saying. What Churchill is saying is it was lack of foresight, not a clear thinking, not the right advice, not the right time of acting. Because timing becomes important. If you act early, you may get away by doing a less morbid work. If you act late, often I teach my residents a correct decision taken late in surgery is a wrong decision. A wrong decision taken early in surgery is still acceptable. And I often repeat it, I'll repeat it again here. A negative laparotomy is better than a positive autopsy. There's no point knowing at the end of it that there was a finding. Negative laparotomy is better. You must always have a relatively lower threshold for opening up. This is precisely what I'm trying to indicate here. Now, after a few principles, these cardinal principles are very important, and I'll request you all to pay attention. It will help to eventually make it possible for you to, I'll just change the font. That's it. Now, the old established principles, don't just reinvent the wheel. Don't try to think of something outstanding or out of the way. Do not reinvent the wheel. Just stick to the basics, and most of the time you'll be fine. The modern scientific understanding of inflammation and infection is important. And remember, when we talk of terms like SIRS, which have now disappeared, been replaced by, actually you should know that it's an inflamed patient rather than an organ. So you'll treat the patient as a whole rather than just the organ. And there is no confusion about it being an evidence-based surgery rather than eminence-based surgery. Eminence has a limited role, evidence has a major role. Now, we often hear residents, seniors, others talking. My experience says that a lot of these patients need this. Your experience should be evidence-based. Except God, everybody has to give evidence, mind you. And there is no confusion about it. So, timely, simpler, effective, evidence-based, reproducible. This is the intervention that is desired. I've summed it up for you. If you're asked, or if I am asked, what should be the ideal intervention? Summary of all that you heard so far. It should be timely, it should be simple, it should be effective, it should be evidence-based, and it should be reproducible. Now you're encountering, we're just giving you, I gave you the, I'm coming to the brass tacks now. So you've heard of the encounters, the cardinal rules. Now we're going to look at the encounters at the point of entry, right? We'll divide them into what encounters you have to, what do you encounter when you're entering, which is when you're making an incision. And remember, I often hear this from residents, and I am not tired of repeating. There's nothing like giving an incision. You make an incision. There's nothing to give in an incision. And we will be talking about incision for a while. That's a beautiful quote by Theodore Cocker, a great man, a thyroid king, who got his Nobel Prize, incidentally, for thyroid physiology, not for thyroid cancer. And what does he say? Incision could be as long as needed and as short as possible. So don't make a long incision to begin with. You can always extend it. And don't unnecessarily make a long incision. You've heard of the old saying or old quote that big surgeons, big incisions. It's wrong. Big surgeons, optimal incision. Now, optimal incision is as much as you need, not want. One of the days when you open up the abdomen like a book to find nothing inside, like you do with a lot of books, and then you close it back. So the patient would have a big scar. You do see these kind of patients once in a while. And you find a big scar, I also would urge you to go through my video on abdominal wall closure and incision making. That's quite focused on this. Well, and you then find another incision which is extended further, you have a battle scarred abdomen, which is a wrong thing to provide to the patient. Now the point of entry. Very often you realize you opened up and it's a difficult entry. What do you do here? See, a lot of jelly material here, and there are adhesions here, and you'll get into the viscous somewhere. Always go from the virgin side. If you don't find the virgin side, go for the extraperitoneal approach. That is, let the peritoneum remain stuck to the contents, and you create a plane till you reach the flanks, and hopefully you'll have a virgin plane. If you don't get it, it's too bad a case. That will happen. That you learn with experience, but it's important. So, difficult entry. The difficult entry, look for the virgin side. If you don't find it, leave peritoneum on the gut or vista, and you will be comfortable. So leave the peritoneum on it so that you don't get into the bowel. And then hopefully, as you're going laterally, you may find that you have a virgin plane. Come from lateral to medial in that case, rather than medial to lateral. So generally, difficult entry would be handled by a lateral to medial approach. Classical scenario, idiopathic, sclerosing, encapsulating peritonitis. This is what is called cocoon, and most people get it wrong. Cocoon is not what you call any plastered abdomen. The term for cocoon is classically, this is described by who et al. And it's the other name for this, idiopathic, sclerosing, encapsulating peritonitis. This is seen in young girls, and at the time of menstruation, they actually throw out a membrane which provides a capsule, and inside this you may have a completely normal gut. That's different from what we always describe. We often describe the gut as plastered abdomen, which will happen in tuberculosis, all right. But that's not cocoon. So cocoon is a very definite term. If you're asked to write on abdominal cocoon, please go through this. I've given you the summary of it. And inside you find the bowel is all right. So it isn't exactly, you may find a jelly-like material which you see here. You may find that it looks like a very bad abdomen. The moment your membrane you open up, there is a capsule which is, the moment you open it up, the entire thing comes out like a snake, and you find the bowel is all fine. And it's not so difficult to bother about. I mean, it is very easy to manage. Cocoon, that is. Don't get it wrong. Cocoon is classically an intact membrane with bowel inside, which is fine. It may look bad, but actually is not. Seen in young girls and usually in the pubertal age group. You will find that there is bowel inside, which is okay to manage. No problem with the bowel. And you will find it is very easy condition to manage. And this is usually a membrane which is coming out of the membrane, within the membrane there. It's basically secreted by. I'll just go back on it. Now this is what you see. This is the classical tubercular abdomen that you people encounter, and it is not, I'm repeating, this is not the abdominal cocoon. This is a classical tuberculosis where you have multiple tubercles all over. It's all stuck, and you may reach into this position. You may get into this situation. This is the ascitic fluid. Classical look of ascitic fluid is classical straw-colored. Tubercular, you'll have these patients coming in obstruction. Do not interfere here. Sometimes it's good to leave it drain and come out so that you live to fight another day. Bottom line is, above all, do no harm. Same thing which I mentioned as primum non nocere. This is of importance, this slide, so I'm trying to slide it if I can. Yes, now We come to a situation, abdominal compartment syndrome, which you often would encounter. It is divided into, I'm quickly going through it because most of the time you must have observed, even in your practice, this is abdominal compartment syndrome that I'm talking about. So don't worry about the top heading not coming. And AES. This is divided into a primary, secondary, and a recurrent. These are the three types. And most of you would answer by saying if the intra-abdominal pressure rises, it is abdominal compartment syndrome, which isn't exactly the complete definition. The complete definition is that in addition to the intra-abdominal hypertension, there's an organ dysfunction, which means any one organ. And that means kidney, heart, lungs, or brain. These are the four organs that we talk about. If in addition to the increased intra-abdominal pressure, there is an organ failure, then it is possible that you will have abdominal compartment syndrome. And you must have observed in your practice, the moment you open up the abdomen, and if you ask the anesthetist, the answer would come, the saturation is improved. And usually it's the urinary output that you look at. The patient with increased intra-abdominal pressure with a reduced urinary output is actually the state of abdominal compartment syndrome. Intra-abdominal hypertension is when it's a term used for raised pressure inside the abdomen, which you can measure by using the Foley's catheter in the bladder. And actually, the pressure could be related to centimeters of water or millimeters of mercury. And centimeters of water is a different measurement. So don't worry about that measurement. I'll just discuss with you. So primary is when there is organ dysfunction and intra-abdominal hypertension in the presence of direct injury to the abdominal contents. Could be trauma, peritonitis, ileus, hemorrhage. Conditions could be. There's so many possibilities. And we need to be clear as to what is the cause here. The moment you do decompressive laparotomy, which I'll discuss, you are done. You will do well. But there are problems relating to that also, which I'll discuss in details later on. The secondary is increased intra-abdominal pressure, where the organ dysfunction is due to third space edema. You've given too many fluids, too much of fluids, or there's quite a lot of third space loss in burns. And the way this fluid is connecting, it will lead to a secondary type of intra-abdominal hypertension. So primarily, you should know primary and secondary. The recurrent ACS happens when the secondary insult starts the cycle again. Very high mortality rate. That is, you have got initially a primary abdominal compartment syndrome, and subsequently you've led to secondary, which is then there is a third space loss, also the wall edema, and that can lead to a recurrent ACS, which is terrible. Because in that case, even if you open the abdomen, it would not help because the loss is somewhere else. It's important to understand that there are three types: primary, secondary, and recurrent. So primary, secondary, recurrent, and usually ACS is intra-abdominal hypertension plus organ delay failure. Now you can grade the intra-abdominal hypertension, which is the next important aspect. Grade 1, grade 2, grade 3. The grade 1 is now visible to you. There's some overlap of slides. This could have something to do with the net connection, but don't bother. Now, grade 1 is when it is 10 to 15 centimeters of water. So 10 to 15 centimeters. Grade 2 is 16 to 25. So remember the measurement. I'll just share with you again. Grade 3, when it's 26 to 35 centimeters of water. There is no confusion about this. You should always remember that you can measure it in millimeters of mercury or centimeters of water. Both options are there. Grade 4 is when it's more than 35 centimeters of water, which is very high. And how much is 1 millimeter of mercury, 1.36 centimeters. That calculation would work. Right? So it is roughly the, what should I say, 1 and 1/3 of it, which would mean that you have 1 millimeter of mercury would correspond to 1.36 centimeters of water. And intra-abdominal pressure is normally zero, or slightly sub-atmospheric. At 15 millimeters of mercury, the physiological changes happen. So if you ask the question, at 15 millimeters of mercury, the physiological changes would happen. 15 centimeters, 15 millimeters of mercury. So you can correspond it to the centimeters of water. So the two can be understood in relation to each other. Right? So grade 1 is 10 to 15 centimeters of water. Grade 2 is 16 to 25 centimeters of water. Grade 3 is 26 to 35 centimeters of water. And grade 4 is more than 35 centimeters of water. Now, roughly 1 millimeter of mercury is equivalent to 1.36 centimeters of water. This is how you look at it. And the normal pressure is normally zero, slightly sub-atmospheric. Otherwise, the abdomen would rupture. That's the pressure you need to keep. Should be kept in check. And 15 millimeters of mercury, the physiological changes would happen. That's a cutoff as far as we are concerned. Before that, abdomen can accommodate the change and the rise in pressure. Now, there are certain conditions which can be the chronic forms of intra-abdominal hypertension, right? We have an advantage of two screens here. So, primary, secondary, recurrent. And the chronic forms could be where persistently for some time the pressure is high, and since it's not acute, you may not have the manifestation of what you see in an acute rise. It can happen due to morbid obesity, something that you often see in patients who undergo surgery for loss of domain or for obesity per se, pregnancy, so I can use it as fetus, feces, and of course, obesity. Now, and how would it manifest? You've all heard of the, preeclampsia as a manifestation of it, which is attributed to intra-abdominal hypertension or like hypertension. Patient may have just hypertension, which is on account of pressure on the IVC, you know that. And it can manifest over a period of time with those features. What would happen if you suddenly decompress the abdominal compartment syndrome? Of course, you will not do it. The reason is it will cause a sudden reperfusion, sudden circulation of the products of anaerobic metabolism, lactate, lactic acid, and also a substance called as MDF, myocardium depressant factor, which actually it causes depression of the heart. And they are basically nothing but acidotic products. So sudden decompression has its issues, and you should understand that it will lead to, I've already mentioned, one is it lead to acute hypovolemia, which will be, please bear with us, there's a little bit of problem with the connection, it's going slow, so you'll find the writing happening later. Acute hypovolemia, you must see it later when I've put it down, but I'll explain it to you, there's no need to worry. There is a decompression of the mesenteric vascular bed. So basically one problem is acute hypovolemia. And the second problem is the release of lactic acid into the bloodstream, which will lead to acidosis and also release of MDFs. And these MDFs They produce supraventricular arrhythmias and episode of asystole, and patient may actually collapse. To take care of this, when you're doing decompressive laparotomy for abdominal compartment syndrome, we use what is called as decompressive cocktail. You'll have a decompressive cocktail, and this cocktail must be used before you decompress it. And we will be therefore using a cocktail which is normal saline, 2 ampoules of soda bicarb, 1 liter of normal saline, and 50 milligram of mannitol. It's a combination of saline, soda bicarb, and mannitol. That's called a decompressive cocktail. And this takes care of the preload, neutralizes the release of acids from the mesenteric circulation, and also stimulates renal diuresis. That will take care of the major killer in this case. Now, when we have the sudden release, I've already mentioned about reperfusion injury, RPI as they call it. This happens in all compartment syndrome, whether it's in the limb or in the abdomen. And if there's a rapid washout and systemic circulation of lactic acids, which can be a dangerous thing to happen, and we need to be careful on that account. What will that do? The potassium and other byproducts of anaerobic metabolism, they are released into the circulation. And what will they do? They will actually make it. So potassium, the marker is taking a while to come down. Products of anaerobic metabolism, they'll all be getting into the reperfused viscera and the lower extremities. It will lead to gut ischemia, regional production of inflammatory mediators. This is reperfusion injury of the abdomen on sudden release of abdominal compartment syndrome. So pay attention to that. There would be gut injury, which will be amplified by increased production of free oxygen radicals. Oxygen-free radicals, OFRs as we call them, they'll be released in large amount, and that will lead to damage to the gut, which will lead to what? Translocation of bacteria. And what will that lead to? Gram-negative septicemia. Either the bacteria would go or their toxins will go, depending upon whether it's gram-positive or gram-negative. This would perpetuate a systemic inflammation. There will be multiple organ and dysfunction syndrome, and there will be death in critically ill patients. This is what you need to look at. So the reperfusion injury can be a killer. So we need to use a decompressive cocktail to make sure that we use it, which is a combination of normal saline, soda bicarb, and mannitol, followed by surgery, followed by management of all the acidosis that is likely to happen due to release of potassium or all the products of anaerobic metabolism. And the abdomen has now been entered. What are the encounters? There could be many. One of them is here, as you can see. Hopefully you can see it. There's an overlap of slides, so maybe that is causing us a little problem. That is again due to the net. We'll try. The ileosigmoid knot, also called as the Gordian knot. This is Gordian knot, which is basically, as you can read, it's ileosigmoid knot. You know, it was in Greek custom, and there was this knot which would go in various circles. And when Alexander the Great had to go out to conquer the world as he wanted to, he was in touch with his guru, Aristotle, And Aristotle took him to this temple where this knot was kept. And it was believed that anyone who could untie it, or unless you could untie this knot, you are not going to go and conquer the world. So most people had tried, starting with Hercules, Samson, Atlas, everybody. And this was attempted by Alexander too, when his guru asked him to untie it. After a while, as he kept looking at the knot, he took off his sword and cut it into pieces. And he said, I'm going to conquer it with my sword rather than by untying the knot. Although it is still believed, therefore, the common phrase, when you can untie, don't cut. Classically, there is a loop of sigmoid with many loops of small bowel at its root or base. Now, it is believed that sigmoid, when rotating, we all know that sigmoid rotates anti-clockwise, which means this way. It drags along a lot of small bowel loops, especially in individuals with a long mesentery of the sigmoid, people who have been fasting for a long time and they suddenly take a feast in the evening, like during Ramadan, especially the custom in the Middle East. But after the Ramadan, they'll take after a fast, they'll take a lot of roughage. And also in some parts of our country where laborers in the evening eat the whole day's meal along with some bit of liquor. It has been found to. I'm drawing it slowly so that you can see it. So one doesn't know. There are two theories. It is believed that sigmoid rotates and take the ileum with it. That's one theory. And the other theory is ileum goes around the sigmoid. In any case, the picture is similar to what you get in sigmoid volvulus, which you can see in this picture. The sigmoid volvulus will be seen. But at the bottom, you also have ileum. Both I'll cover in this. Classically, sigmoid volvulus is seen in elderly individuals who are mostly vegetarians. It is also seen in prisoners or psychiatric patients who keep lying in a constipated state, so their sigmoid is loaded. And as the sigmoid is loaded, like in all vegetarian animals, you see a long sigmoid. When the sigmoid is long, it has a long dysentery, which is narrow at the base. The loaded sigmoid is therefore vulnerable to rotation. And this is what is actually the case in sigmoid volvulus. Almost a similar situation. And classically, it's a large bowel obstruction. Large bowel obstruction is gradual in onset, gradual in progression, and there is distension, but it all happens a little later. And subsequently, of course, when the patient gets ill, there is fecal and vomiting, provided the ileocecal valve is incompetent. The thing takes about 24 to 48 hours, maybe more. But in ileosigmoid knotting, it takes a quick 12 hours to 14 hours, which means there's a marching of events. Why? Why is there a marching of events? There's a small bowel obstruction along with a large bowel obstruction. So the small bowel obstruction will produce the classical triad of distension, constipation, and of course the vomiting. In sigmoid volvulus, vomiting is not the initial presentation. They come with distension, constipation, which is a major presentation. Now, the same picture of uh, the sigmoid volvulus going rapidly is what is suggestive of it being uh, ileosigmoid knotting. And you can see this part of it you saw earlier. This is the initial part, which is the large bowel, and subsequently you will see the small bowel. In this case, it is collapsed, but here it is distended. So you can see that small and large bowel obstruction. So some bit of small bowel has got dragged along. And this ileosigmoid knot is also called as The iliopsigmoid or Gordian knot needs an emergency surgery, and you've got to act like Alexander. That is, don't try to untwist it. Why? What will that do? You may actually allow the necrotic material to go away. You just got to disconnect wherever you are, do an ileostomy, or make a stoma in whatever way. Both will be first taken out, and then we'll have this handled differently, this handled differently. I hope that is clear. It's an important aspect of learning, so I thought I'll take care of it. That is about the sudden encounters. I'm not talking about what is expected. I'm not discussing intestinal obstruction here, which you know how to manage. Or you can refer to my presentation on intestinal obstruction, which is also on YouTube, and you've all been also shared. There is a discussion on iliopsigmoid knot, partly there also, but the rest of the features relating to intestinal obstruction are clearly managed. The management is clearly discussed. Then there is an entity called as obscure GI hemorrhage. You find the patient was taken up for surgery and you don't find any source in the upper GI and in the lower GI. It is somewhere in the middle, in the small gut. So bleeding somewhere, that is hemorrhage somewhere, hemorrhage nowhere, hemorrhage in the small bowel. For that, therefore, you look for hemorrhage in the small bowel. Now, hemorrhage in the small bowel cannot be reached from above or from below. Therefore, we call it obscure. I'm leaving a lot of space for all of you to ask questions subsequently when I finish with this presentation, because there are many aspects that are very basic. So I've kept it to only those aspects which are unexpected encounters. So hemorrhage nowhere, hemorrhage somewhere, hemorrhage in the small bowel. Now, there's various ways to look at it, and I would just briefly discuss it here. You have done an upper GI endoscopy. You've done a lower pardon me on the handwriting, it's got to do with the writer. It's not working as smoothly as it used to work with me, maybe due to network connection, but I think you can understand. Both are negative. I'll take a lecture on obscure GI hemorrhage separately. And you then have options like capsule, video capsule endoscopy, or you have push enteroscopy, which very few people do it now, or virtual colonoscopy, virtual and enteroscopy, etc. Mecal scan, which is done for the most common source of hemorrhage is from the mecals diverticulum, which has some bit of peptic mucosa, which can actually cause bleeding. And moving on, you may have strange scenarios. This you would remember I discussed with you even in the presentation on acute abdomen last time. You're familiar with this. It is actually the napkin ring appearance. You can see multiple spots of obstruction. This is typical napkin ring appearance, which goes usually with multiple strictures. Never ever do stricturoplasties unless you cannot resect. The best answer is resection, because if you don't resect it, it's a disease you're left behind. Bypasses are also considered a bad option. You have to cover all, therefore I'm taking a little while. You can see this has been managed by resection and anastomosis at most places. No or minimal bypasses. And never mind, it's not drawing well, so I'll just skip that part. This could be due to, this is obscure GI hemorrhage. It's due to malignancy, which again would be a presentation that you can find there's an obstruction here, which is due to malignant stricture. needed resection. One was not expecting this as a cause. It was a young patient who need to be resected for subsequently managing the obstruction, which is the primary problem here. When it doesn't write, you have to bear with me. I'm trying to do some bit of jugglery to make you all understand. Gallstone ileus, remember, it's a dynamic obstruction. It needs a connection between the biliary tract and some kind of a fistula with the bowel somewhere. It can follow a Merizi, it can follow scenarios where the stone tumbles down. That's why it's also called as tumbling stone or tumbling obstruction. And then it goes and gets stuck at the terminal ileum, say about 2 feet proximal to the ileocecal junction. And lots of calcium deposits on it. And therefore, this is a radio-opaque gallstone. Most of the gallstones are not radio-opaque. This is radio-opaque on account of calcium that deposits on it, and it produces an intestinal obstruction which is dynamic. Don't be confused by the term of ileus. It's a dynamic obstruction. Management can be 1 stage or 2 stages. You will either manage the, I think I'll move it to the next slide so that you can maybe see some part of it. You can do a single or a 2-stage operation. Most of you are recommended to do a single stage operation, take out the stone, do a stoma or do anastomosis, and then in a second stage you go for the gallbladder. There's no point going for it in the same stage because it's inflamed, and in any case there is a complicated cholecystectomy that will follow, so it's avoidable. And in any case, he's not going to do or she's not going to die of it in the immediate future. So you should take it up as, or if you're interested, please go through this article. You'll get the details of it. How to manage it is clear in that article. You can make a diagnosis by doing an ultrasound. Some people like to go for a CT scan. Now, this is a very important topic, and I thought I'll take it separately. Most of the time, the features are non-specific, and I'm sure all of you have seen the scenarios where you found that the patient was waiting to be taken up for bowel, for pancreatitis, or for some other condition, and you find when you open up, there is a gangrene of the bowel, and it's a fatal condition where by the time we open up, we find that most of the gut is already lost, and we need a very low threshold to go in for this. Early clinical picture may be non-specific, and you may actually not know what to do in the initial phase. The CT can be the diagnostic investigation of choice. Not always possible to do, but there will be a past history of abdominal angina, hopefully. But when it's venous obstruction, you may not get this history. Venous obstruction is unfortunately also more common and more morbid. The lab studies will also be very normal till the bowel is lost. So you know what, until the time the bowel has lost its viability, you may not get any clue. So there's no cue, or there's no way you can approach it beforehand. So very high index of suspicion. High index of suspicion is mandatory. You need to keep a possibility of this, especially in situations where if you put a drain and you find hemorrhagic fluid coming, and you think it's a hemorrhagic pancreatitis or some other condition which is producing a hemorrhage, and it turns out to be a nasty nightmare. We should be careful about this condition. Right, I've mentioned now here the CT scan or CT angio investigation of choice, but it is an operative surprise. So what do you do in this case? When in doubt, take it out. This is what we teach. And the reason is simple. You'll have to take away the dead bowel. Don't wait for anything. And what do you do to the dying bowel where you have a doubt? In this case, you may do, there was an old concept of doing re-laparotomies, where you will go in by repeated laparotomies to find out if the bowel is viable, or how much is the line, where is the line of demarcation, and how do you go about managing it is what you look at. And basically, it'll be go back and see, like you see for the chronically ischemic limb, how much is, where is the line of demarcation developing? Very often you may not get that advantage. It may not be always the case. What do? You will have re-laparotomies, which have been replaced by laparostomies now. So you can have an incompletely closed abdomen where you can go in and see for more bowel to be resected. But you have to remove the dead bowel. The dead bowel cannot be saved. The dead bowel has to go. The dying bowel, you can actually wait for the line of demarcation to come. It is necessary to understand that this is more often than not going to be an operative surprise. You would not be prepared for it. But if you are prepared for it, then of course you have many options. An investigation of choice in hindsight mostly is CT, angio, and most of the time you can't make that diagnosis. But how do I personally would recommend that you go for it? Suspect it in any patient who's looking sicker than the abdominal signs. It's not pancreatitis all the time, remember. And don't rely on amylase, don't rely on lipase initially, because initially they may be sensitive, but they're not specific. Even in this condition, you may have a derangement of these enzymes. So it is possible that you may actually uh, miss it out. And most of the time, that's how it happens. What is the operative approach? Now, this is classically an acute abdomen with peritoneal signs. It's a ticking time bomb. You know you're losing the gut every minute. So it is better to open up and see. Remember, whenever in doubt, take it out. Open the abdomen. Don't keep these patients on expectant management for too long. I've already discussed in the past, expectant management is a conservative treatment by a surgeon. The patient should be in a surgical ward and you should have a low threshold to open up. If in doubt, open it and see. Many a times I've found that it's salvageable and you can resect the bowel and save the patient. Now, if the patient is ill and you think the patient has got the features uh, which are suggestive of peritonitis, but the patient is not as sick as you would think. So it's a ticking time bomb that you're looking at. So we will be wiser in opening it up. And there is no indication for angiography in most cases with the pattern all totally destroyed. Now, what would you see on? I'm taking a little time here because this is some condition which you'll encounter and you'll have to deal with when you open up for peritonitis or pancreatitis. These conditions do happen. The appearance of the bowel is frankly gangrenous, or it may appear ischemic or dusky, as I mentioned, or it could be of questionable viability. All three conditions I've partly discussed. If it is frank gangrene, and if it is entire small bowel combined with right colon involvement, suspect superior mesenteric artery thrombosis, you can resect, and even duodenocolic anastomosis is tolerated, but nutritional support is mandatory. And if in about 50% with less than 3 feet bowel, they may survive. Mortality with the bowel length being less than 3 feet is more than 50% or at least 50%. Now they can be surviving on TPN, and something that we practice at our center, which is enteroclysis feeding, where we have the both the loops brought out. We have the proximal loop out. Bear with me for the picture, please. And with the distal loop also out. Whatever it is. If it is large bowel, it is large bowel. We have it out. And what contents come out of this are fed back into the system. The enteral nutrition can work. That's enteroclysis feeding. We practice it in all our cases, the protocol that we follow in our unit, and they do well. And a lot of them we have been able to go back and close. And you would be surprised to see the extent of uh, the colonization of the small bowel that happens and ilealization of the colon that can happen, which means that you can have some bit of viable bowel working for you. And we may actually eventually save these patients. If it's a dusky bowel, what can we do? Observe. What do you mean? How long will you observe? Same, warm packs, 100% oxygen, and always look for supramesenteric artery. How do you look for supramesenteric artery? Well, if you're finding it difficult to reach it with the anatomical landmarks, you can follow any supply of the small bowel in the mesentery, trace it down to the supramesenteric artery, and you can see if there is a pulsation visible. Mostly, as I said, if it is venous, you can't do much, but arterial, there is a possibility to take out the thrombus, use a Fogarty, or if you don't have Fogarty, a pediatric Foley's to take it out. There's no fear of bleeding, because if it was bleeding, there would be no problem. So you're looking at a non-bleeding supramesenteric artery, right? Now, if you have a bowel which is less than 3 feet long, we should try to go back and do re-laparotomy, where you can simply close the skin and open the skin later on. Close the skin, open the skin later on. But if the intra-abdominal pressure is high, it is better to keep it as a laparostomy. You can go back and have a look at it again. If you have a handheld Doppler, you can look for the perfusion, which is not difficult to find out. Let me tell you, it's possible to take care of it even in this situation. Now, you can actually, the supramesenteric artery can be, we can look for it. Now, these terms like intraoperative fluorescent angiography. Now, in good setups where there is a possibility of window sign in green now, it's possible for our people to see the viability. Let me tell you, it's a clinical judgment that's going to work, and it's usually as good as these gimmicks, and these gimmicks don't really help in the emergency situation. You should be prepared to make a clinical decision, and I'm repeating, if it is dead, remove it. If it is dying, that is dusky, observe, 100% oxygen, warm saline packs, palpate for supramesenteric artery, see if you can do the thrombectomy by making a nick over the thrombus and flushing it using heparin solution and flushing it out. If it revives, good enough. Otherwise, do re-laparotomy if it is less than 3 feet, because less than that is hardly going to, patient is not going to survive. The nutrition is really compromised. Like I mentioned, 50% is still an achievement. Something is better than, better than not doing anything worthwhile. And clinical judgment is going to play the major role. That's what we will be looking at in most of these patients. Now, the question comes whether we anastomose or we don't. I moved away from any situation. Now I'm just looking at unexpected encounters. I'm leaving a lot of areas barren for all of you to ask questions. Now we don't know, and a lot of times you will find answers which are vague, and you will get an answer even in the ward rounds that we do for the courses that we conduct. The answer is, I look at the gut, I look at the fecal content of the peritoneal cavity, perforation, etc., etc. These answers can be very subjective. What looks like a good gut to you can be a bad gut to another, and what looks like a bad peritoneal cavity to you can be a good peritoneal cavity to somebody else. We rely on scoring using Apache to score, and we have published this data. If the score is less than 10, it's a reasonably good scenario. You can do the anastomosis. This becomes a resident proof system where the score less than 10 would mean that I can do resection anastomosis even in this condition. I'm talking about the ischemic bowel while extrapolating it to any other situation. If the massive resection is involved, that is half the bowel is resected, you would suspect, even if the score is good, anastomosis is poorly tolerated. We are, in any case, having a doubt. When in doubt, take it out. So take out a stoma. The other thing is stomas are visible outside. Post-operatively, you can look at the blood supply. They can really help you in knowing if the gut is viable or not. With the stoma outside, if it is pink and nice, then you know you resected the dead part, and the part that is remaining inside is going to take over. So you take a decision based on that, but by and large, in most scenarios, you won't be able to find a simpler answer to this question. Because then in the end, it's the management of the patient, and we rely on the score here, which is the Apache 2 score. And as I said, 10 please take it as 10, and more than 20. Less than 10 and more than 20. These are two critical. If the score is okay, I'll speak. Forget about it. If the score is more than 20, it's patient is not too fit, is not fit for any anesthesia. So you would rather optimize this patient. Patient is not fit for any surgery. Optimize the patient by putting in bilateral flank drains, resuscitating in an intensive setting, bring the score down to less than 20, and then we do what we do for group 2. In group 2, invariably we exteriorize. That is worst. So that's the protocol that we follow, and it's worked for us. We have published the data with reduction in mortality and morbidity, and it is possible to do that. The only morbidity is a stoma, which we can manage. Second lobe operation, a word about that. If I have done a laparoscopy, which is better for me, I don't need to really work too hard on it, but laparoscopies have an issue of evisceration of that. If you can just, the intra-abdominal pressure is normal, patient's overall condition is acceptable, then you can simply close the skin and open it. Some people even put towel clips on the skin, put loose sutures. The only problem with putting tension band sutures, which I don't recommend, please go through my presentation on abdominal wall closure, is that gut, which is edematous, can rub against the string. So this is the string, the gut is rubbing against it. It can cause what is called bowstring effect, and bowstring can cause perforation. So we would put just gentle skin closures just to keep a layer over the gut. The laparoscopies take care of intra-abdominal hypertension. If there are no stomas, relook if doubtful viabilities. And the options, if it is viable, everything is doing fine for you, then there's no problem. You can actually observe for recovery in the blood supply. A word about mesenteric venous thrombosis. I've already covered the arterial thrombosis. I have not discussed the perforations, which I've covered, acute appendicitis and perforation peritonitis, which I've also covered. I have not covered the frank hemorrhage, which has also been covered. I've covered obscure GI hemorrhage, and now I'm talking about the ischemic bowel, which is a problem that you encounter. Mesenteric venous thrombosis, fortunately, is rare. It may follow portal hypertension or portal pyoemia and needs aggressive management. What is that aggressive management? No clear guidelines, you are in trouble, because most of the time the gut is edematous because of the venous block. And it is called venous gangrene of the gut. Like in the limbs, venous gangrene can be deadlier than an arterial gangrene. You find it as an operative surprise. Dissect the dead part and hope for the best. This is the CT triad of mesenteric vein thrombosis. Here, CT is the investigation of choice. You can't make a preoperative diagnosis. Even in mesenteric arterial ischemia, you can suspect it because the patient might give you a history of abdominal claudication or features of abdominal angina. But in venous obstruction, you may not get those features. There's no history. And you get a CT triad, which is hypodensity in the trunk of mesenteric vein. They could be associated intraperitoneal fluid, and in addition, thickened segment of small bowel. This is a classical CT triad. Hypodensity, the mesenteric vein, associated intraperitoneal fluid, and thickened segment of small bowel. If this triad is present, you suspect it. And you can do some bit of praying here because the outcome is not great. They don't do very well. Now, revisiting approach to mesenteric ischemia. Now I'm summing it up. Suspect ischemia before intestinal gangrene actually develops. Easier said than done, but should be our aim. Diagnostic or therapeutic angiography can work out for us, which is actually the same thing as the embolectomy that you do in any limb, where you can find out beforehand that there is a block. Then you can do a therapeutic angiography. Now, this will help you improve the intestinal perfusion, and also it will help you know the line of demarcation during laparotomy. And when you actually find there is a doubt, exteriorize bowel or execute second loop operation. This is the guideline that you should have in your mind. If one wishes to see the survivors of this horrendous condition, aggressive intent is mandatory. And most of us have no choice but to be aggressive in this condition. And a lot of us will be finding it as an unexpected encounter. And this unexpected encounter needs an aggressive approach. You cannot be less aggressive. An aggressive approach will save some of them, and maybe about 30% can survive if you have a good management. The other aspect was this is a hemorrhage classically of surgery in the sigmoid region, and it was extending down to the rectum. What you're seeing here is sacrum, and there is a plexus which is called presacral plexus. It can be a challenge to actually stop hemorrhage, and you have seen what I'm trying to show here are thumbnails, thumbtacks being used, not thumbnails, I'm sorry. These are the thumbtacks. We use this thumbtack. Actually, I've used it in post-APR bleeding sometimes. What you're actually doing is you're putting thumbtacks directly, and you can see them. They're autoclave thumbtacks, and it really works. And the thumbtacks have just got to be told in the patient, the post-operative X-ray, that these are the tacks that I've used. What do? You have a thumbtack here. The nurse has kept it in the, it has autoclaved, and then you can put a little bit of sponge stun on top of it and just punch them into the foramina. And punching them all around stops the bleeding. We have seen it work, especially in the presacral plexus bleeding, which can be horrendous. No pressure, patience, packing. We know that. Pressure, patience, packing, and prayer. These are the 4 P's. Pressure, patience, packing. That is, you apply pressure for some time, have patience for it to act. Don't just quickly see. Then apply the pack and let it work for some time. If the pack is not working, then you will be, when you apply the pack, you'll wait for the pack to work. And during this time, you can read a prayer. Now, don't start with the prayer. That's one thing I tell all my residents. It's the action that you need to do. While praying, which prayer you offer is entirely your take. Now, this is how it looks on an X-ray, and I'm sure you will see it as it comes on the screen. Yes, and bear with us, the net being slow, pictures are taking a little while to show up. It is something I wanted to share with you. These are the thumbtacks which will be visible on X-ray. Thumbtacks are the usual thumb pins that you use for putting on the board. See here also, the lateral view. They can help you stop the excuse me. They can help you stop the bleeding, especially from the presacral plexus of. It's a major bleed, actually, very difficult. Most patients die if you don't manage in time. Nothing else works. We haven't seen anything else work. Okay, so some encounters which were unusual. This case I discussed with you, 2-in-1 case of acute abdomen. This, what you're looking at right now, is the gangrenous appendix, which has gone around through the mesentery of the small bowel to produce intestinal obstruction, and you have obstruction here. This is the proximal loop, and this is the distal loop. It can happen. So one is surprised to find these kind of encounters. You find some freak encounters here now. And we need to manage both in such a way that we are able to salvage the bowel. In this case, it was possible to do a appendectomy first, and then you could see that bowel was still viable, although it is quite a difficult situation to deal with because patients are morbid on account of 2 pathologies. This is to show, this picture shows the back side of it, where you can actually see that there is appendicular gangrene, and the appendix has gone around through the mesenteric opening. How it happens is if you can go back in time, then maybe you can think with the hindsight that there is uh, an opening that it produces by inflammatory reaction. And it's a little slow here. That's why probably you're observing the difficulty. And you can see that the inflamed or the gangrenous appendix has gone through the mesentery of the small bowel and produced that noose. By inflammatory reaction, it can do that, create a hole in the mesentery and it's come around. It's a rare presentation. We have published this, and because it is rare, so we have published it. So finally, when we removed it, we find that the bowel is manageable. After appendicectomy, we didn't have to resect this bowel. It was just relieved spontaneously. It's still happening. What drew our attention to the case was a bad appendicular story, because the gangrenous bowel, appendix had all the features. Patient was opened up for the same reason. The obstruction would be managed as a fallout. You can see that it is now looking like a normal bowel here and normal bowel. So moving on to the other encounters that you may have any number of encounters. It's impossible to cover them all in one go. Bezoars. There was no history, there was no suspicion, and this is actually a cotton bezoar out of the gut. Patient came with features of intestinal obstruction. She was a tailor by profession, was very keen on knitting. Actually, not a tailor. These are those people who work on the carpets in the western part of UP. And she came with an intestinal obstruction of some duration. And on opening up, you could feel there's a big mass in the bowel. And on opening up, you could find there was this tail coming out, and you could pull the entire bezoar out intact. And actually, it was fitting into the entire bowel and going into the distal part of the bowel into the ascending colon, which is something of a Rapunzel syndrome. Rapunzel is classically, you know about the fairy tale story where the Prince Charming was hanging the hair for the princess was hanging there. I'm so sorry. I'm so preoccupied with the slow movement of the marker that sometimes there's a stop in the flow. So please pardon me for that. Now the princess is hanging her hair and for the prince to climb up, and this is classically the Rapunzel syndrome. Classically, the Rapunzel syndrome is where from the stomach, where the main collection is, there is well, it's still not working. The hair would be coming down into the small gut and duodenum and small bowel. Here, kind of a reverse Rapunzel happened. That's how you published it. It's a rare scenario. All you need to do is you need to take care of the patient's psychiatric state, need a psychiatric opinion, to open it up and make it a point that the bowel is resected, anastomosis is done. The question can be answered easily now. It will depend on the score. If the score is in group A, I'll anastomose primarily. If the score is in group B, I'll do an ileostomy. If the score is in group 3, that is more than 20 Apache score, I would optimize the patient, no anastomosis, no surgery, and until the score improves, I'm not going to get it. So these patients won't survive the surgery. Now, if there is a doubt and I'm borderline, I'll exteriorize. Whenever in doubt, I will take it out. Freak encounters, again, you can see the CT scan here. This lady underwent cholecystectomy 25 years ago, came with intestinal obstruction and a big lump. So what you observe here is big CT was done in this case. And what CT showed was, because the diagnosis could not be made, the CT showed, I'll just show you here. You can see that there is a bezoar, not a bezoar, it's a textiloma. Textiloma is you found sponge inside, and it's 25 years she survived perfectly all right. A classical CT appearance with trapped air, and you find that there are multiple air is trapped with a very nicely made capsule. The whole thing had to be removed, and you can see that there are bits and pieces of gauze pieces here. Now we move on. This is a textiloma. which is you can see a very nicely. I mean, I already covered that part, but I'm repeating it for some people who could not possibly see it at that point in time. 25 years back, she had undergone cholecystectomy, and she came back with intestinal obstruction and vague abdominal lump. And CT was done, which shows a classical appearance. You can see some trapped gas or air in the well encapsulated mass, and it's got a thick capsule. The appearance is classical, and one goes in to remove it and manage it as we should do. These are those rare encounters that you may not always get, but when you get them, you should manage them as we are possibly trying to discuss. Now, don't worry about it. We'll share the PPT with all of you, so there's no confusion on that. And the webinar will also be recorded so that if there's anything you missed out, you'll get it. Now, so that's a textiloma or a gossipibioma. Now, we move on to another very rare scenario where the patient was opened up for acute abdomen and there was a twisting of spleen. Patient had splenic infarct and the spleen had gone and got stuck in the pelvis and rotated. So that's uterus. A very old case, so the picture is old, and you can see on top spleen. This is spleen, and uterus is below, spleen is above, and it's a wandering spleen, as you can see, with a very long pedicle here, and you can actually have a situation where this twisting can produce infarction of the spleen. This is the spleen which is infarcted. But on rotation and detorsion, it became all right. Should we put the spleen back since it was an adult and we didn't want to take a chance with it? Wandering spleen is commonly seen if the splenocholic or renal ligament is lax and the connections with the diaphragm are lost and goes anywhere. That's why we call it wandering spleen. You'll have in that case to do a splenectomy and it will be an easier one. You just got to ligate it here and you're done. Now, and these are those scenarios which are extremely rare. That's why I'm discussing. There's so many possibilities in the abdomen as you open up. We know that it's a Pandora's box, and the Pandora's box can surprise you with findings each time that you open up. So this again, being a rare scenario, I'm sharing with you because you may get this. This was a wandering spleen that we had published, which is actually to get idea about very rare situations. Now this is a very, very unusual case. The gentleman had been following a tantric, and I operated in early 2000, which means it's an old case. You can see on an X-ray, the patient came absolutely fit and fine with an X-ray, which you can see on the right side of your screen or the left side, where you can see the blade of a knife, looks like a kitchen knife blade. And he didn't give any history of ingestion of anything, or there was an incision on the abdomen. It wasn't looking like a surgical knife, but was referred by a surgeon in Uttarakhand. He sent it with the patient being absolutely fine for this knife to be removed. We took a lateral view also. It was looking like a kitchen knife and just the blade of it. Patient did not give a good history of any kind. You opened up and you find a very interesting picture, the second picture that is, where there's a clasp knife, which is, it is gone and produced a connection between the proximal and the distal bowel with a loop in between. Now, this is what kept him alive, and this was very, very interesting case. And in post-operative period, you can see you can see in this picture I'm trying to draw. The tip of the blade is the knife is here, and the handle is on the left side. That's the rear side. This is the handle, which is the wooden handle. And we were surprised to see this finding. The whole theater was jumping here and there. Everybody was wondering what is happening. Now, we also did not know. We dissected an anastomosis segment, and that's a segment you're seeing, so that we could analyze it later. And this loop was defunctionalized by a connection right here at the bottom. Now, this is what kept him alive. You can see this was the knife that we took out. And later on, he gave us a story that he was following the instructions of a tantric, and under the influence of some bhasma, he, after having fought with his family, had introduced this blade through his umbilicus into the abdomen. Under the influence of some drug. And imagine how far deep he went. And it is actually it's such a rare foreign body to report. So that I was sharing with you. I'm sure this is one very, very unusual one. And you can see that in spite of now there's a problem with the server, so please bear with us. We're trying our best. The connection as well as the server. So now they were initially the encounters at opening, then when you opened up, and then while closing, you therefore need to be going through all these encounters in different ways. And I'm looking at all three steps, and gradually I'm going to discuss with you whether we should close an abdomen or we should not close an abdomen. It's an important question. A good rule of thumb is that this is a rule of thumb I would share with you, but this is not quotable, and don't quote me to people who probably would not be aware of it and they may actually take offense. A good rule of thumb is that if when looking at the abdomen horizontally, as you can see here, the guts can be seen above the level of the wound. The abdomen should be left open and we must do temporary abdominal closure. That's a rule I follow and I'm sharing with you. It's an easier one. What I have added to this, and now we're doing it as a project, is we also take the intra-abdominal pressure, and if the pressure is more than 15, we are not going to close this. You can argue that if the abdomen is closed and then it opens up, what is the problem? The problem is the burst abdomen, the nature would do, because if the abdomen is not going to stay closed, there's no point closing it. But then you can argue, let it open when it opens. If it may work out, why not at least attempt it? The problem is, which I discussed with you, with the abdominal compartment syndrome, with the reperfusion injury, the physiological damage would have already happened. With that happening, it is possible that it is possible to avoid this confusion and stick to making it a safer option to leave the abdomen open. The patient would survive. You can always close it later. And some people do simply the skin closure. We do Eurobag zipper laparoscopy. In fact, the first one we did in way back in 90s, and we published it. So it is also patented with us. The reason being, we were the first to use it. Before using it, I was using Marlec zipper, which I got from UK, and I wanted to use them in some patients before I gave a project to my resident. I found that Marlec zipper, which was costing about 200 pounds at that time, I don't know how much is it now. It was with mesh. So the bowel used to get stuck and they'll be interpreted especially. I didn't like it. After 5, it was by one of my residents who suggested, sir, why can't we use something else which is transparent and easily available? And he was coming out with an idea. We thought of Eurobag. And a lot of you are using it, Bogota bag. Bogota bag is a bag made in Bogota. It's a place in Brazil, which is a big bag just to accommodate. It's the same modification. So don't close an abdomen that's not closing. It's a bad practice. I'm not writing anything here because it may not write well. So I'm speaking, so pay attention to what I'm saying. Now, you can have a situation where a Eurobag zipper, you can see we have used. And clearly the Eurobag zipper does for us quite well. And sometimes you can do without it. And when we published it, it was published in 2003, which was after some years of using it and collecting the data and publishing it. We found that you could make the Eurobag zipper in less than 10 rupees because the zipper was available in the market close by, and we were able to make it out of a simple Eurobag. And it worked very well at the hands of many people. And it was shared with many people during the ASI time when I was the national secretary. I circulated this to all the surgeons in the country, and a lot of them were very happy with it. So I think it's worked, and this is one way of doing a Eurobag, the zipper laparoscopy. Don't close an abdomen that won't close. That's what I wanted to share with you. And there are temporary abdominal closure techniques available today, where you can actually do the temporary closure and use the suction to do the same thing that topical negative pressure therapy does in abdominal closure in any wound. That is creating a pressure which is gradually allowing it to now join and heal. Now, what that does is gradually there is a decrease in the oxygen supply at the surface, called as topical negative pressure therapy. And this topical negative pressure therapy is going to create the angiogenesis, which is typical of PNP therapy for any wound, and also the gradual pressure can bring it to the center and doesn't let the edges go away on either side. Now, this would ensure that we are able to do a gradual closure. We have created our own tack also, which is using simple OT sheet here with multiple holes. It doesn't stick to the bowel. I'm completely against tension band suturing for the boosting effect, which I mentioned. And you're closing the abdomen unnecessarily. And then we leave a suction drain in the we can use a suction drain here and apply a steady drain, provide a seal of it. And what that will do is, this is a suction, it's connected to a suction. And you put a steady drape here, which will seal it completely. When that seals it completely, the abdominal negative suction will also be able to work. It's a reasonably good way to do it. We do that regularly in our ward. This is something we practice very frequently. And it is possible to apply the negative pressure temporary abdominal closure technique in these patients. Well, this marker is working slowly, but I'm trying to use the dots to explain so that you can get a clear view of the temporary abdominal closure technique that we use. So these are the various techniques that prevent abdominal compartment syndrome. Laparostomies, I've discussed. On-demand laparotomies, re-laparotomies. Dictated by patient's condition, mortality of 30 to 76%. Or you can do what is called a STAR procedure, which is staged abdominal repair. You can do serial operations, and what that can do is, it is possible to, yes, you can actually, now with temporary laparoscopy you can manage, and basically it's planned beforehand. It's serial operations planned beforehand or during first index operation and performed every 24 to 48 hours with temporary laparoscopy. It can be done with the patient in intensive care without taking him to the theater, but possibly in the theater condition it should be done. Now, these are the surgical techniques in the prevention: laparostomies, on-demand re-laparotomies, staged abdominal repair or STAR. That's a demonstration of the picture of the tag. I can see it before you can see it, so that's why I mentioned it. This also we published. This is something which is a temporary abdominal closure technique, and you can see the suction tube in place here, and that's a I already given a graphic demonstration of it, and this works with the negative suction, and this is what you can do. In a lot of them, it works quite well. While doing it, it's important to keep the whole area dry, and what do we do for that? We use super glue or Fevikwik, which is also a good layer to prevent any erosion of skin. Something that again we used and published, which is a super glue. I will not use the pen to describe it. So it is very, very important to follow some of the publications that we've done in the past. Now, well, at the end of it, before I conclude, there are a lot of things I wanted to cover, which I tried to the best of my ability. In the study of some apparently new problems, we often make progress by reading works of great men. Do you know nothing much has changed in the management of these encounters? We've got an armamentarian, some extra additional armamentarian with us, but the outcome would depend on your good clinical judgment and the timely intervention. And you call them apparently, they're apparently new problems, although you call them new problems. We often progress by reading works of the great men of the past. Now, that's a summary of what I wanted to talk. And then I think we can take questions. Thank you very much for listening patiently. And I hope you were able to listen to it. Whatever you couldn't see or hear, you will be passed on, definitely. Now we can have the questions, maybe.
So the first question is by Dr. Mathai Jolf Koshi, and he wants to know, he's asking, approach when one cannot find the site of perforation in the presence of clinical radiological evidence of hollow viscous perforation or pneumoperitoneum.
Well, that's a good question, and I would, first of all of you, when you can, well, your diagnosis is perforation peritonitis and you don't find a perforation. Well, first of all, you must understand the meaning of exploratory laparotomy. When you start looking for it, you should have a pattern to it. You're starting from the stomach, you go down to the duodenum, then you go down to the ileum, look for the DJ and trace it down to the small bowel, the terminal part. Now, excuse me, can I have the PPT off, please? Now, if that be the case, you start with 3 steps. The sites which are usually missed. The second and third part of duodenum. Of course, it will depend on what the patient presents. The posterior part of the first part of duodenum, posterior wall. Rectum, rectosigmoid, and the ascending and descending colon. These are the sites. So what do you do? It will depend on the presentation. If you suspect it to be duodenal ulcer perforation, you need to cauterize the duodenum and leave a gauze piece there, which is fresh, preferably a pack. Don't use gauze pieces in the abdomen. Use a pack. So use an abdominal pack with a marker. Leave it there. Why? You've not found anything, but you leave it there and start looking for perforation anywhere else. The idea is you can always visit it back, look for any staining, because it is all dried up. Give a good wash and look for it. As soon as you'll open up the abdomen, you'll have a gush of air coming. So we are not looking at the artifact of the radiology showing you perforation, and there is no perforation. So that part is taken care of. We leave a mop in the region which is supposed to be second and third part of the duodenum after you've cauterized. Leave the mop there and you start visiting for the complete bowel walk, as they call it. Do it again, do it slowly. I've seen it happen. You just quickly go like this as if you were the smartest and cockiest resident in the town. Don't do that. Go slowly and let your assistant to also see carefully. There is a lot of people like to put it through the saline in a bowl loop for this leak test, which you do like a man who fixes up your, the tire punctures. Now that's one way, but first go through it quickly and look for it as you do the good, decent bowel walk. Then you look for the cecum, ascending colon, and look for it again by carefully putting in some saline and looking for some leak. Right? You can't take the ascending colon out, it's a retroperitoneal structure. Then the flexure, another place where you may miss it. Fill it with saline and look for the leak. Sometimes you can find it. This is a technique I employ. I'm sharing with you. Now, I have already got a pack in the second part of the duodenum and I've left it alone. Right? Then I'll go along I'll do the classical explorative laparotomy, which means starting from the pelvis, going to the ascending colon, liver, right lobe, transverse colon, left lobe, splenic flexure, down to the descending colon, sigmoid, and then rectum. Very often you find it's the rectum. So you need to do a very thorough search of it. We can move to the next question now.
The next question is by Dr. Sulai Raj, who's writing, have this multiple anastomosis caused post-operative adhesions in the patient or not, sir? Have we followed this patient of multiple strictures? With that's also
Something in addition, 60% with.
No, sir, that's the next question.
All right, you're asking about this question, which this case, which again is a very old one. We operated in 2000. Now, I'll tell you one thing. If you get multiple strictures, something not unusual, and if I have just one stricture, that's no difference. If there's only one stricture, I'll resect. I'll not do strictureplasty. Strictureplasty is a bad operation. Reason is strictureplasty leaves the disease there. What is strictureplasty? We all know it. Opening it longitudinally and closing it transversely to widen it. The disease is there, it doesn't work, it fails. But if you have multiple strictures spread all over, you can't resect out the whole gut, then some strictureplasties are acceptable. That's number one thing to understand. Very clear? Number two, do we bypass strictures? That is, we do ileo-ileal anastomosis, ileo-ileal. Bypasses are horrible operations. They lead to blind loops, and multiple blind loops lead to infection, which lead to irritable bowel syndrome, malabsorption, and it's a horrible thing. The best treatment is if you can resect the disease. And then comes the question of, can you anastomose? Now, if the score is good, you should. But sometimes you don't have a choice. There's just so many strictures, but they're spread apart. If there are multiple strictures in one segment, we'll resect. So you're talking about a very minor casualty. Every and any operation in the abdomen can make a patient vulnerable to adhesion. So forget about it. There is one perforation, one stricture, 2, 3, 4, doesn't make a difference. There is something called as a vulnerability towards formation of adhesions. Some patients are abdominal cripples. They keep coming back with a minor. Do you know the most common cause of adhesions in the abdomen? The most common cause of intestinal obstruction is adhesions. And most common cause of adhesions is post-appendicectomy, which is not multiple strictures. And gynecological positions in ladies. So there's a vulnerability also, one thing. The second is too much of handling of gut can definitely induce, but decent, gentle handling can reduce. Now, this patient came at least 5 to 6 times, not because of adhesion, but because some strictures will reform. This is a tubercular case. And ulcers, as soon as they heal, patient had received all anti-tubercular treatment. So it's very little that you have to give away for saving the life of a patient who's come in intestinal obstruction. So strictureplasty is a bad surgery. If can be avoided, should be avoided, because you're leaving the disease behind. 2, bypasses in the intestine with strictures is a bad surgery again, because you'll have malabsorption. And 3rd, resection is the best surgery. Multiple strictures in one segment, you can resect and anastomose. But if they're widely spread out, some resections, some strictureplasties is what a lot of people would do. Adhesions can be found in this case as well as in other cases, but adhesions per se due to this is a tubercular case. Handling of the gut, the least you can ask for. But every adhesive obstruction doesn't need surgery. We manage it by urografin contrast studies. Urografin as a diet, as a therapeutic diet. A lot of them recover. We don't need to operate them regularly. Next question, can we have?
Next question by Dr. Amok Pathak, a 60 years female with history of abdominal hysterectomy and incisional hernia repair in past. Now recurrent subacute obstruction. Diagnostic laparoscopy shows multiple complete small bowel adhesions converted to laparotomy. Shall we do complete adhesiolysis of small bowel adhesions, as during which chance of bowel perforation is more, and again may have recurrent adhesions? So how shall we proceed in such situations? Critical SMA without small bowel changed. Oh, that's a different question. In such situations. The next question is critical SMA without small bowel changed on CT on day 1. Started on heparin, but pain increases. Signs of peritonitis over a day. Shall we repeat CT to look for bowel changes or take up for laparotomy, and shall we wait to take patient for surgery to see the effect of heparin for 24 hours. This was
I have a request, make questions short. This is a lot of time you wasted in writing the question, but the question is valid. I'll answer your second question first. We'll take up for surgery, no repeat CT. This is a waste of time. And invariably, you'll find if they have signs developing, no confusion. If the patient has peritoneal signs, I don't treat the CT, I treat the patient. Patient goes in for surgery. The question is very good, but try to finish so that we can cover it up. And going back to your first question, you were given again a long question scenario. I mean, the patient has got adhesions due to previous incisional hernia repair and hysterectomy. So there are adhesions. And adhesions are adhesions. Now, you put in a diagnostic scope, which is a smart way to exclude. Now, why should you do adhesolysis of the entire gut? Nobody will. We'll just fix the problem and live to fight another day. As you very correctly mentioned, I appreciate that you understood, Amol. If you dissect out each adhesion, you're going to create more adhesions. Adhesions lead to more adhesions. And there are a few things you can do here. One is you can infuse the patient with. Now, a word about why adhesions form. I thought I'll cover it here. Do not use a lot of lavage, especially with agents that are not unsafe. Betadine has been found to be epitheliocidal. Metrogyl has not been found to be useful. Saline, which is slightly lukewarm, is the best. You read your textbook, sometimes they say 10 to 12 liters of saline, which means you'll finish off all the saline of the hospital. Just wash it adequately. If you do a thorough, unnecessary wash of the peritoneal cavity, you'll wash away the opsonins, which are protective, and you'll also increase the risk of adhesions. Do not use gauze pieces to wipe too frequently. They are also a cause of adhesions. So prevent them. Bowel handling should be minimal and careful. Do not use diathermy to dissect out these adhesions. Use a cold knife or cold scissors for this. Do not try to handle the bowel roughly. Fine open blade dissection with scissors, I teach my residents. Just small bites, small mistakes. Small bites, small mistakes. Don't cut through like a tailor does. Small bites, dissect. Small bite, sharp dissection, no blunt dissection. But remember, you don't need to take off all the adhesions. You cannot, firstly, even if you do, it changes nothing. I'll just look at the part where there is obstruction, relieve that obstruction, and maybe I can use Dextran 70 lavage, which I've seen. Dextran 70 has been found to be useful, given to the patient, sorry, and we can hope for the best. But don't clean the hell out of the abdomen. That's what a lot of people do. Saline after saline after saline until short of sending a postgraduate inside the abdomen, everything is done. Not to be done. Just be gentle with the gut and adhesions won't. Your second question I already answered, Amol, which is a brilliant question. It can happen that CT doesn't show anything. Clinically, patient is worsening. Between the two, which one is going to guide me? Clinical. We don't treat the CT, we treat the patient. How would it change into signs? Patient will develop tachycardia. There'll be abdominal peritoneal signs in the form of tenderness. There'll be guarding or rigidity. Leukocyte counts will go up. There'll be electrolyte abnormalities happening. This patient needs to be taken up for surgery. I would repeat, a negative laparotomy is better than a positive autopsy. Do go in and exclude it. Next question.
a patient with atrial fibrillation on warfarin now presents with abdominal distension, pain, melena, INR is 4, and the plain CT possible due to not possible due to deranged KFT. How do we differentiate intraluminal hemorrhage and mesenteric ischemia? CT shows dilated bowel loops. What would be the management?
Now, see, first of all, don't make a webinar into your personal problems. It should be worthwhile for everybody to understand something out of it. You're talking of a scenario which will happen in many patients due to heparin-induced intra-abdominal pressure, also raise in intra-abdominal pressure, or patient may be having features of, what you're referring to is patient has got mesenteric artery-related issues. How would you rule it out whether there's hemorrhage with the bowel or not? They're two different problems altogether, right? And in all patients with melena can not always be due to hemorrhage per se. Melena could be a feature of strangulation also. Now, if there are features suggestive of strangulation, I would rather take it as strangulation than just the hemorrhage. Now, if CT angio is not showing you any site where the hemorrhage is happening, what are we looking at? We are looking at what are we looking at? Thrombosis or venous arterial or venous thrombosis. So it will be treated as a case of mesenteric ischemia. Can we read through the question again because there's a lot
So, a
written.
patient with atrial fibrillation on warfarin now presents with.
Well, go slowly. Atrial fibrillation on warfarin. So patient has a tendency to throw emboli and has pain and melena. INR is 4. Plain CT possible due to deranged RFT. How do we differentiate intralumbar hemorrhage and mesenteric ischemia? You can't differentiate simply going by what you have just said. CT showed dilated loops management. When CT shows dilated loops, did it show any hemorrhage into the bowel? CT can make out. There's no contrast, that's why you're struggling. What would you do? You'll keep thinking about what can happen or you'll go in. Now, if the patient is fit and patient can withstand the investigations further, you would be going for anything further. Short of that, you'll correct the INR, you will hope for the best and you look for the abdominal signs. You mentioned only distension and there is pain and melena. So I would still err on the side of ischemia as a factor rather than anything else. And showering of emboli is one manifestation, although the patient is on therapy, but it can still happen. And if that happens, the CT alone, where the contrast is not used, may not be useful. So you'll have to give the benefit of doubt to the patient and you'll have to probably go in for surgery. Can we take the next question?
The next question is by Dr. Naina. So, what are the various types of bowel sounds? How to differentiate between normal bowel sounds, tingling, borborygmi, and others clinically? Some information regarding bile. Yes, sir, sorry.
This question is by Anandi.
No, this is by Naina about the bowel sounds, sir.
Okay. What about the various types of bowel sounds? How to differentiate between normal bowel sounds, tinkling, borborygmi, and others clinically? Well, you need to hear them to know them. And some uh, sounds, tinkling would be like a tinkling of vessels. I would rather go by any exaggerated bowel sound as relevant. They don't really matter. Borborygmi is different. Borborygmi is not what you hear with a stethoscope. You'll hear that. Even without, it's loud and clear, actually. Lima Charlie, as I call it. Loud and clear. It's shouting. The bowel is asking for you to act. And tinkling is usually those initial features of obstruction where the bowel sounds. I mean, frankly, between me and you, it's very similar to the murmurs that you heard in cardiac posting, where when the moment you make a diagnosis of mitral incompetence, it becomes a pansystolic murmur. First out sound is feeble, murmurs relating to the axilla. All these things are relative, and the only thing you need to therefore rely on is whether they are exaggerated or they're normal. A silent, tender abdomen is a feature of peritonitis. Exaggerated bowel sounds are a feature of intestinal obstruction. Next question is refeeding in the.
Some information regarding bile refeeding in the proximal stoma with high output.
I think I described it. Probably missed out, Dr. Harshvardhan. It's a good question. It is refeeding we do routinely, but what I mentioned as enteroclysis feeding is essentially that. What we do, if suppose the gut that we have got, which is coming out, it's an invariably practiced thing in my unit at least. A lot of people practice that. If the gut that is left behind is very small, we normally bring it out. And the distal part also we try to bring out. If we cannot bring it out, we'll put in a catheter to make it into, a tube to make it into a tube colostomy or a cecostomy or whatever. So that whatever bile comes out of the proximal stoma, it can be fed into the distal to create an extra corporeal shunt, you can say. So, but don't keep that effluent for too long because enteroclysis feeding should be very carefully done. It is pushed in as an infusion in the distal loop, but you collect it and use it as quickly as possible. Otherwise, the bacterial contamination and nitrogenous products can really cause encephalopathy in these patients. So use it quickly, but you don't need to really filter too much if it is proximal bile, as you're mentioning. The advantage being you take care of the retention of bile, which is useful, and peripatetic circulation is restored, and you have enteral nutrition persisting, so villus atrophy doesn't.
So the next question by Dr. Anandi, technique of exploring thrombus in superior mesenteric vessel, and is it mandatory?
Well, that's a good question, Anandi, and congratulations for that. I hope you heard me say that. If you can have a bowel which is dead, black and dead, then you're going to achieve nothing. In fact, you will cause reperfusion. So reset that bowel. Okay, so that part is done. Now, if the bowel is dusky and there are patches, you suspect there are emboli. The case that somebody had put earlier in an atrial fibrillation patient, classical with those patients, and patients with thrombus that can be thrown, showering of emboli. So they have patchy gangrene of the bowel. It's a good case to follow the supramesenteric artery, which has its anatomical landmarks. But I teach my students to just go down to the DJ, go a little laterally, you'll find it. Or trace any of the vessels to the root of mesentery, and you'll find supramesenteric artery concessions there. You can actually see it. It's not difficult. Once seen, you will be knowing it. Look whether it's pulsatile. If you are handheld Doppler, look for its pulsations. If you can salvage the rest of the gut, this is the only time to do it. You can make a small neck, and I'm telling you, it's not impossible to do because this is not going to bleed. Because if it was going to bleed, it's good news. But have a bulldog clamp ready, or a vascular clamp ready, apply it proximally. Have a distal control also. Make a neck, take out the thrombus, keep a Fogarty ready, and then release the proximal the clamp for the bleeding to happen. Some bleeding would happen, but then the pediatric size Foley can go in or Fogarty can go in, and you can push in heparin through that, and you can take out as much as you can. Push in heparin again, then do it distally as far as you can, and you can simply close it like any arteriotomy. Make a small neck only, and you can actually remove it. There is an indication in a in-between kind of a bowel, patchy gangrenous bowel, but in a dead bowel, no indication.
Next question by Dr. Milan Joshi, how to deal with cholecystoduodenal fistula in case of gallstone ileus case?
Don't deal with it in the immediate setting. You don't have to do that. I described it. I think you probably missed it. And Milan had shown the approach. It can be two-stage approach or one stage. One stage is where I've taken the stone out. Patient is very fit, unlikely. These are usually elderly patients who have, uh, bad performance status mostly. What would I do in these cases? I'll just get the stone out, restore, and save the patient from acute abdomen. What is the cause of acute abdomen here? Gallstone ileus, which is a dynamic obstruction due to a stone which is usually has to be more than 1.5 to 2 centimeters to block it. And that happens in the distal or the terminal ileum by tumbling down with the stone and calcium depositing all around it. You can actually remove the stone and live to fight another day. Don't treat it in the same setting unless the patient is supremely fit and the surgeon is extremely competent. Now, if a resident is operating, look at a resident proof system. Resident proof system, I'm not calling it foolproof system, but resident should be doing bare minimum to take the patient out of it. Don't try to do what is not actually indicated at that point of time. Later on, there are various ways to manage it. Now, coming to the part two of it, if you're doing two-stage, the patient is fit, investigate get an MRCP done to look for what kind of a MEDG communication it is, or can you leave the patient alone? There's no stone there. Can it form and throw it? Patient is going to live that long. Depends on many factors. If you've decided to go in for surgery, it's like you need to reconstruct. And a lot of us use a good gallbladder patch to cover the defect and close the. You disconnect the two and close the duodenal opening as duodenal opening. Like any fistula, take a little rim off the duodenum and remove the gallbladder or keep the gallbladder, depending upon whether you're going to use it to patch it, and then close it. But not in the same sitting. It's not a great idea because you are likely to land up into trouble in that case.
Next question by Dr. Kush Parekh. An obscure GI bleeding from small bowel intraoperatively, how to find source and point of bleed in small bowel when lumen filled with clots?
Excellent question, Kush, and I'm glad you made it short. Don't give an example which becomes a little longish. Time is an issue. Otherwise, I am with you all the time. And even those who gave long questions, I think the questions were brilliant, and they were writing it in a hurry, so they had to write it. Coming to this is a brilliant, brilliant question. If you have not been able to localize the bleeding, now I'm repeating again: hemorrhage somewhere, hemorrhage nowhere, hemorrhage in the small bowel. And usually it's in about 10 to 15% individuals. There was a time when people did blind right hemicolectomy. It was all gone now. You should have done investigations beforehand. I also showed you in the slides the Nickel scan needs to be done, but not possible all the time. So you are talking about a gut which is already full of clots. I assume that patient was fit enough, and upper GI endoscopy ruled out us bleeding in the stomach. Colonoscopy ruled out a bleeding in the colon, but that happens in a fit patient. When you opened up the patient, I use what is called as multiple clamp technique. Use a bowel clamp or use your fingers as clamps, right? Keep going after you've pushed out all the clots into the large bowel. Clamp and see if it wells up. Multiple clamp. Keep walking, clamping, 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 clamping. Where you find it wells up, stop there. Open it. That's where the bleeding is. Now, this is multiple clamps being used. Otherwise, on the table, if you're in a good setup, you can put in a scope through an enterotomy and go and visit all inside and see where the bleeding is. Give a lavage, clear it off, and look for the bleeder. In a good setup, you would have done a CT angio and localization, and maybe embolization, and maybe technician scan would have shown you where is the bleeding coming from. But these things don't practically happen. Therefore, I like your question, Kush. If you have obscure GI hemorrhage and you don't find hemorrhage in the stomach, stomach looks good, you can palpate it. Colon looks good, you can palpate it. It's a small bowel that is loaded. Now you're looking for a source there. Go for multiple clamps, and where you find in between the clamp welling up, that's where the source is. Now, if there is a doubt and you can't find anything, do you do a blind right hemicolectomy? Answer is no. Now, if the bleeding is in the large bowel and you're not finding the spot, there is a case for doing subtotal colectomy, because blind right hemicolectomies don't really help. Very common cause if the patient is elderly are angiodysplasias or AV malformations. They usually happen on the left side of the gut. Small gut, the causes could be, like I showed you one case, that's case of obscure GI hemorrhage. Actually, in this case, we found a tumor, but you could see a little narrowing there and we could locate it. But in cases where we can't locate it, use multiple clip or clamp.
Next question by Dr. Waqas Ahmed. In case of tuberculosis, which area should be biopsied and what lab investigations are necessary?
Well, that's a very trivial routine question. The gut has got no relevance. It's the lymph nodes. And if you read tuberculosis properly, the primary complex is Bones focus, lymphangitis, and lymphadenitis. So we should find most of the disease in the lymph nodes. So when you're operating, always take a lymph node biopsy. The gut specimen that you send will have ischemic ulcer, ischemic enteritis, or end arthritis. A tubercle ulcer is known to produce strictures because the ulcer is ischemic. It has end arthritis of the vessels rather than, so that it stimulates fibrosis. That's why tubercle ulcers don't perforate. They perforate only when the patient is immunocompromised. Fibrosis doesn't happen, HIV, steroid therapy, etc., etc. So the best place is to take it from lymph node. Now, don't ask me about the routine biochemistry that you do and the RNA testing, and there's some gene panels that have come. That is done routinely. And when you're operating, the best place to take the biopsy from is the lymph node, not the gut. Gut is not the best place.
So Dr. Dinesh is asking, a 69 years old female presented with large bowel obstruction. Imaging showed transverse colon mass. Intraoperatively, tumor was found to be carcinoma stomach, infiltrating into large bowel. Should we relieve obstruction or resect the primary also?
Well, that's a good question. You had imaging beforehand? No, transverse colon mass. Intraoperative, you're surprised to see carcinoma stomach infiltrating into large bowel. Why would you remove one separately? The whole thing will be connected, no? So you cannot resect the tumor if the patient has got disseminated disease. If the patient doesn't have a disseminated disease, the best palliation for carcinoma stomach is surgery. The best palliation for transverse colon malignancy is surgery. How are you going to relieve the obstruction without resecting it? But the patient has to be fit for it. Now, therefore, I don't normally entertain, without the whole idea. If the patient is 70-year-old, that doesn't make patient unfit. Performance status of the patient, the other parameters, scoring. If they're all fine, patient is fit for surgery, resection is the best option. If the patient is unfit for surgery, you will make sure that there's no gastric outlet obstruction. So what if there is a gastric outlet obstruction also, and transverse colon is also obstructed? What am I going to do? It's a very simple answer. If the patient is unfit for surgery, feeding gastrostomy and ileostomy, because I want the patient to live and provide some palliation. But if the patient is fit, so therefore put the condition completely. Resection. But priority is obstruction here, not malignancy. So I'm dividing it into 3 scenarios. One, if the patient has a good performance status, there is an obstruction which is complete in the stomach as well as in the transverse colon. There's nothing I can do. Bad performance status, sorry. Then I'll have to do a jejunostomy, feeding jejunostomy, and an ileostomy. So I bypass the stomach and the transverse colon both. But if it cannot be stomach alone and transverse colon alone, because stomach malignancy has gone into the transverse colon, which is known to happen. Then both need to be resected. After you resected, you can, if the patient is fit, you can do a Billroth 2, or you can do a gastrostomy with feeding jejunostomy, with ileostomy. These are various options, but totally depends on the patient's condition. So preference, priority is what is the patient presented to you in emergency with? Intestinal obstruction. Obstruction has to be relieved. Resection, if the patient is fit to undergo resection, is the second best option. If resection is not possible, diversion is the third best.
The next question is by Dr. Chayan Gupta. A 70 years old man presented with distended and tense abdomen, presented with absolute constipation for 4 days.
You mean obstruction? Yes, it's right intestinal obstruction. Okay.
On digital rectal examination, no ballooning but liquid stool. On X-ray, abdomen distended, sigmoid colon loop arising from left iliac fossa akin to volvulus. On opening of abdomen, only distended whole length of colon and a viable length of ileum, otherwise normal. No history of diabetes mellitus, hypertension, or previous neurological deficit or any other drug intake. What to do in such cases?
You're talking of pseudo obstruction. This happens in the large bowel, happens in elderly. Now, in fact, this was being discussed only last week about a case. If the large bowel is distended, only large bowel is distended or small bowel is also distended? Normal small bowel. Large bowel is distended and the stool can be definitely liquid, which happens due to spurious diarrhea. Exclude, go back, revisit, and do exclude a growth in the rectum or rectosigmoid junction, which you can't reach through DRE. So go from above and DRE both. So do examine it again. This is very, very important, what I'm discussing now. Is it a growth which is just about one tiny ribbon? That can be a cause. Now, if there is a lot of fecolith in the large bowel, it can undergo decay and come out as spurious diarrhea while the patient has got obstruction. That's one option. Now, if you find nothing in the large bowel, but it is distended, it is narrowed at the rectum rectosigmoid junction, exclude a functional blockade of rectosigmoid or something lower down. If you find nothing, and I assume that you found nothing, do a colostomy or do an ileostomy. If you do a colostomy, sigmoid colostomy, you're basically going to fail again because there is a blind loop that you've already got. The ileocecal junction is not competent, is competent. So what I would recommend and what I would do in these cases is a terminal loop of the small bowel as ileostomy, and we'll make the ileocecal junction incompetent by pushing in a Foley's through it into the cecum, inflating the Foley's and pulling it through. So the ileocecal junction becomes incompetent. Breaking into the thumb and index finger is sometimes not very effective. It's a good question. It does happen. I'm not talking about oliguria or those syndromes. They will also happen. But what do you do in that situation is important. You can always live to fight another day and investigate. But first of all, revisit the case, exclude it by going from below and above at the same time. Try to push in a Platus tube from below. Your assistant can do that, and you see how far it goes. If you ruled out every possible physical obstruction or anatomical obstruction, you're looking at a physiological block that can happen in elderly, and due to constipation or fecal matter being there, a patient being completely bedridden. In that case, it is safer to do an ileostomy than a colostomy. That's all I thought I'll share with you. Can I mean, just see what is here written here? Akin to volvulus. Yes, it does happen, because what happens is the sigmoid is the extra loop and usually loaded with the fecal matter. It looks like the classical sigmoid sign is visible this way. That is the omega sign or Fryman-Dale sign. Fryman-Dale sign is where the three radiopic lines are converging down at the towards the right iliac fossa. And we don't normally do anything fantastic or outstanding or something which is going to kill the patient at this point of time. Next question. So we'll do a ileostomy and work up the patient for the cause.
The next question by Dr. Mohana asking incidental finding of Meckel's diverticulum, whether to remove or not.
Well, Meckel's diverticulum, if it has got a narrow base, if it is too long, if it's looking loaded, suspicious, you can do, some people do a wedge resection, close it. A lot of people prefer to do resection and anastomosis. Just because you find nothing, remove it is not necessary. If you've got a wide base and it is smallish in size and it doesn't seem to be having anything nasty, and you're looking for an emergency scenario where it's not a clean theater, not everything is clean, you can even leave it. But personally, if you're asking me, I suspect that it will get bad at some point of time. Sometimes there is some bit of gastric mucosa in it and can produce obscure GI hemorrhage. In fact, it's one of the important causes, about 20% in younger group, where we do a Meckel scan, as I was mentioning in the previous question. It's safer to resect it, but depends on the patient's condition. We should add to the morbidity. And remember, don't make it worse than the patient's condition. If it is a wide lumen, short length, not likely to get obstructed, not looking loaded with anything, doesn't have anything abnormal in it, you can leave it. But my answer is you can resect it. Next, please.
We have taken Push Parikh's answers.
We have taken.
And the next question is by Dr. Ashish Kamatham. In a case of ruptured appendix on exploration, it is found that there are dense clumping of bowels in the right iliac fossa with no sign of the appendix. How do we proceed, keeping in mind that the patient might go into obstruction subsequently? Is dissection in a densely clumped mass looking for the appendix advisable, sir?
No, not advisable. And if you have to do it, you can always do it later. But how did you make a diagnosis of appendicular perforation? These are usually flimsy adhesions. They are not the adhesions you are worried about. If the adhesions are flimsy and if you can go from periphery towards the center, the core is don't go from the center to the periphery in these cases. Periphery to the center. If you can clear off, it is of course ideal to look for it, and you must find it. It's not impossible to find. Sometimes what you cannot find is not necessarily because it cannot be found. It could not be searched properly. And it's a good time to invite and call your senior into it. You need experience to dissect it. One very good technique to dissect in the adhesions, which I will share with you. Keep a warm saline in your big syringe. Your assistant can keep flushing it with saline as you keep going with the scissors and dissect it. It is possible to get the appendix. But otherwise, if you think it has to be a decision to be taken with somebody wise, always call for help. Call a senior person to help you. If it is looking like a difficult dissection, which is going to create more holes, it is safer to leave a drain and come out and hope for the better in the future. Because worse comes to worse, if the appendix is sloughed out or it's lying in an innocuous area, the drainage would happen and it gets localized in a young patient who's fit. If the patient is elderly, poor performance status, anesthetist is scribbing, score is dropping, leave a drain and come out, rather than dissect and create the problems.
So next question by Dr. Vishwas. He's asking, a patient with gas under diaphragm posted for emergency laparotomy, intraoperatively no evidence of perforation but huge retroperitoneal hematoma, probably aortic dissection or blood from aorta. Next appropriate steps are what would it be? Should we evacuate the hematoma or not?
No, any retroperitoneal hematoma should not be explored. We've discussed it in our some of the webinars previously. They're graded also. And you're mentioning at the same time there is aortic dissection. You would have done some investigation to know that. If there is aortic dissection, you need a proximal and distal control. And presently, the hematoma is serving as a tamponade. Before you release it, take help of your senior again. Don't manage it yourself. You need a proximal cross clamping and distal control. And again, it depends whether it's a suprarenal or intrarenal disease. Because if you're putting a clamp and if it is intrarenal, sorry, then the supply to the kidneys can be affected. And I mean the other way around. Okay, if it's suprarenal and you block it, kidneys should not suffer. The patient would have ischemia only available for some time. That is if you have decided. Don't explore a non-expanding hematoma which is retroperitoneal in a hemodynamically stable patient. If the patient is hemodynamically low, sometimes it may give you a false impression of no bleeding happening because the blood pressure is low. Get the help of a senior colleague, your mentor, and also if you can afford a vascular surgeon. Otherwise, you need to cross clamp and a dissecting aneurysm or a ruptured aneurysm or a AAA rupture, which is an emergency you people don't see very commonly in this part of the world. It's common in the West, where you have the aorta opened up. You need to clamp in both sides and you need to put a graft, PTFE or neovascular graft, something, which are necessary to manage it. So for you, a retroperitoneal hematoma which is not expanding, never explore it. Because the moment you explore it, you're going to create a disaster for yourself. Beforehand, even if you've decided to explore it, must have a facility to have a proximal control, distal control, and intervention capability. It's not enough. If you think the patient is sinking and you don't have time, you're calling your senior, use a mounted sponge and press it right at the hiatus against the vertebra to stop the bleeding for the time being, pressing on the aorta. Mind you, it will compromise the renal circulation.
The question by Dr. Pachori, what are the signs of techniques to determine the viability of bowel and mesenteric injury during surgery?
I think we have discussed it partly, and one is by gross look. You can use a Doppler. You can do a indocyanine green study. Fluorescent study is also good. You can see the flow and find out, and there are ways to find it out.
So Dr. Kiran is asking, a 40 years female with no known comorbidities with acute abdomen of 1 day duration with diffuse distension and not past stool for 3 days, clinically generalized guarding, hemodynamically stable, with KFT deranged, amylase
RFT deranged.
How to go about in such cases where there is doubt between acute pancreatitis and other causes of acute abdomen which needs opening?
Can I read it again? Slowly. 40-year lady with known comorbidities, no known comorbidity. Acute abdomen, 1 day. Diffuse distension and not past stool for 3 days. Clinically generalized guarding, hemodynamically stable, RFT deranged, so you can do contrast CT, raised amylase and lipase, abdominal girth, which is a useless thing to manage. Nobody measures abdominal girth anymore. Doesn't really help. It always falls 2 days, but pain worsening. How to go about in such a case? There's a doubt between acute pancreatitis and other causes of acute abdomen. It needs opening. Very, very important scenario, and I think I discussed it. Acute hemorrhagic pancreatitis and strangulation of the gut can almost create a similar picture. And some people used to put in a needle or 4-quadrant tap or diagnostic peritoneal lavage. Since you cannot do a CT, who should get a benefit of doubt? Patient. You must not delay surgery in these patients, provided there are features. Remember, pancreatitis would have a history which will suggest it. The mesenteric artery thrombosis will have a history of abdominal angina. The only thing where you don't have a history is venous obstruction, which is seen in very few patients. So most of the time you'll have to work very hard at the history. Again, this being 40-year-old, unlikely to be due to the embolic phenomenon as people refer to. You mentioned no comorbidities, but your threshold for opening should be low. There is a case for diagnostic laparoscopy in these patients. And diagnostic laparoscopy can find out if the gut is involved. If it is not the gut, if the gut is all right, you can suck out the abdominal the contents also. You can actually reduce the toxicity there also. It doesn't hurt the patient, and diagnostic laparoscopy is possible in most cases. If you think the gut is normal, then it is pancreatitis. If the gut is looking diseased, then you go in. Suppose you cannot do laparoscopy, you don't have the facility, the patient is not doing well, not improving, the Apache score is deteriorating, go and operate, exclude the bowel gangrene. Strangulation is to be excluded. The next question. Prognosis and time of second stage surgery, post total gastrectomy, feeding jejunostomy for corrosive injury of stomach. Well, that's a takeaway question. You can't time it, you can't plan it. Depends on the kind of corrosive injury, depends on the kind of damage. With alkaline corrosive injury, there is more damage to stomach because there is pylorospasm with alkaline injury, and also the alkaline injury is deeper down in acidic ingestion. There is coagulation necrosis on the surface, which prevents the seepage down, and in alkaline, the damage is more. So if the whole stomach is gone, you've removed the stomach, you've done post-total gastrectomy, feeding J, corrosive injury of the stomach. It depends on the age of the patient and the status of the cervical esophagus. Most people forget it because when there is a consumption of the corrosive, it is possible that in swallowing fast, alkali goes down and you may have a normal esophagus. You need to at least give a period of 6 to 8 weeks. And if the patient's condition improve, you've not done an esophagostomy, which you didn't mention, depends on the esophagus, because end of the day, you're going to take the jejunum up into the neck or transverse colon. The cervical esophagus with which you're going to basically anastomose should be also healthy. So if the cervical esophagus has to be given some time to heal, it's about 4 to 6 weeks. That's what I thought. And then it will of course depend, but subjective. And if you're using transverse colon as a conduit, which can be substernal or subcutaneous, there's so many options. You can actually do it relatively faster. If you're using jejunum, then it's not a great conduit. A lot of people don't like to. Then you lost the source of feeding. So keep the jejunostomy there. Transverse colon goes up there. We anastomose the other colons together, and we have still got a feeding J to feed. Then we can allow this anastomosis to heal over a period of time. So it's about 4 to 6 weeks. The next question is, volume is low in the current scenario, acute abdomen. Okay.
Dr. Anandi asking in the current scenario, acute abdomen and COVID-19 positive guidelines, how early we can close the proximal stoma?
Well, you'll have to wait for the right guidelines. People are not familiar with, and if you want, we'll post those guidelines on the WhatsApp group. Time is limited, so we'll take only questions that are direct. Now, the guidelines are, they don't deter any surgery, but naturally you can wait till the COVID times are sorted, and it is possible that we can do a better job of it at a later date. Their guidelines.
Sir, I mixed the two questions. She only asked what to do with acute abdomen and COVID positive patient.
Okay, there are two different questions. Sorry. Yes. Other one is by Harshvardhan again.
Yes.
Now, I think I've answered the COVID times question.
That we can't deter the surgery.
Yeah, we can defer it for the time being, and we can wait for the right times because most cold surgeries are now stopped. Now we can wait. Which proximal stoma you're talking about? Okay, in any ileostomy, etc., we can wait. We should delay it at this point of time. We are not closing them. Second one is guideline. The SSO,
Acute abdomen and positive.
acute abdomen means surgery, and the guidelines are take all the precautions. And the universal precautions would be not the COVID precautions that you take. You have to make sure exclude the positivity in the patient, and the anesthetist would be more keen than you are to find it out, and then go ahead and manage it as such. There are guidelines which I'll post in the group. I think that will be easier.
So I think this is the last question now by Dr. Harshvardhan. How early can we close the proximal stoma?
I think I've answered that. There are studies to show that you can close that's a good question. We are doing a project to see if there is any difference between closing it in less than 4 weeks versus closing it after 4 weeks, and we have reduced it to 3 weeks. It is possible to close it early if the patient condition is fine and the theatre time is not a problem. So early closure is now recommended. So people do it from 3 weeks to 3 months. And a lot of people are rigid on 3 months. That's no longer acceptable. Always is always wrong in surgery. Never is never right. So a lot of people would do it early. And there are studies to show that if you do it in less than 4 weeks, it is as good. And it is possible that you can actually make it. I think some people were talking about the volume. I hope the volume is better now. So some people would prefer to do it at 3 months, some at 3 weeks. We take the middle path usually, and depending on the volume and depending upon, we have a huge volume of cases, so you can't close them, and you can't close them immediately. But I think 3 to 4 weeks is fine. It can be closed early.
Right. So, and if in case it's a high output jejunostomy and we want to close it early, how early can we?
Good, very good question. Excellent question, Harshvardhan. I like it. The 3 weeks would still be needed. You need to build up the patient, and but don't delay it. In high output fistula, the closure should be early because we need to restore enteral feeding, and we need the losses so much. The output is only increasing. You will measure that the patient's BMI is dropping, the weight is dropping. You can find all the markers of nutrition going wrong. So these are the patients where you can go in early, but 3 weeks is fine. I normally do it in 3 to 4 weeks.
So that was the last question.
We can revisit all the questions. Anybody who has got a question can ask now. Maybe you missed out some question. There were just too many, and all of you asked brilliant questions. And Amok, I liked your question, and you shouldn't have left. Well, with that, we conclude it. And I hope you enjoyed it as much as we enjoyed getting it to you. These webinars are essentially to share with you whatever we can in these difficult times, and we'll keep it as a regular affair. And we'll appreciate if you can get back by writing that you could interact and you found it useful quickly, so that we know that you all been listening to what we've been talking. And it'll really be important that we'll appreciate if you can actually see and hear. Some of you must have felt that some questions were inadequately answered. Well, there was a limitation of time. So if you could get back to us with your comments, that'd really be handy. Now, may I request you all to write down that you heard it right through? Can we close it? Quickly, please. Yes, would do. Okay, with that, we'll conclude today's webinar, and I will once again thank Sukruti for making it happen. And we apologize for the internet issues. There's nothing we can do about it. Of course, it fluctuates. We're suffering on that account. So whatever was not heard or seen, we'll get you the PPT as well as the entire webinar soon. And thank you very much for listening to and also tuning in. And hopefully, in near future, we'll get back to you. Over to you, Sukruti. Thank you very much. God bless you all.
Thank you, sir. This session and the webinar was very enlightening for all of us. Thank you so much, sir, for the valuable time. Thank you, sir.